Thank you, sir. This is our case, the unusual outcome of an abdominal trauma. Our patient was a 19 years old male admitted to the emergency treatment unit at DGH Novarelia with a history of 2 days fever, loin pain, left-sided loin pain and vomiting. On examination, blood pressure was 190 and pulse rate was 108 and temperature was 100 Fahrenheit. So from the ETU, patient has transferred to the medical ward suspecting an UTI. At the medical ward, when patient examining, they have diagnosed acute abdomen and patient has transferred to the surgical unit. At the surgical ward, the hidden history is appeared, which was patient has fallen from a tree and there was a blunt trauma to abdomen 2 days back. At that point, they have done an urgent ultrasound scan, which confirming splenic rupture. So after that, they have gone for an emergency laparotomy. At the laparotomy, they have seen multiple splenic lacerations with perisplenic hematoma and splenectomy have done. While examining other visceral organisms, they have seen multiple small abscesses-like lesions in the liver. So they have taken biopsies and specimens for microbiological investigations. Let's see what are the causes for this type of multiple liver lesions. This could be non-neoplastic causes or neoplastic causes. Non-neoplastic causes may be liver abscesses, miliary TB, or fungal infections, or this could be neoplastic conditions like benign tumors like multiple hemangiomas, malignant primary liver tumors like hemangioendotheliomas, or secondary metastasis. At this point, the histopathological examination to differentiate these causes is essential. For a correct histopathological diagnosis, we need detailed clinical history and other investigations like microbiological investigations, biochemical investigations, and relevant radiological investigations, if possible, for probable differential diagnosis. In this picture, I have you can see 3 different diagnoses, which may be a cause for multiple liver lesions. First one is granulomatous inflammation, like in tuberculosis. The middle picture is a benign hemangioma. The last one is a malignant primary liver cancer. In our patient, histology showed multiple abscesses in the liver as well as in the spleen. There were multiple bacterial colonies. We can see we saw with bacterial colonies. With that, we proceed with the gram stain, which showed gram positive coccobacilli. Rest of the case will be discussed by the consultant microbiologist. Over to you, Madhu.
So how did we got involved here? It was some time ago, actually. This is a real scenario. A call came from the surgeon, casualty surgeon, at about 8 p.m. telling that they have done a laparotomy on a young boy, 19 years old, who had ruptured spleen, and when they remove the spleen, he has observed some spots on the spleen as well, apart from the rupture. And at the same time, when he looked at the liver, he has seen multiple small abscess-like lesions on the liver as well. So both liver and spleen were affected by something. And then, of course, they have taken biopsies for microbiology and histology, as he said. Then my question was whether the sample, microbiology sample, was taken to the sterile empty bottle or sterile bottle with normal saline. And not very common though, a mistake being done in the theatre, it was taken to the formal saline. And you can think about the outcome. So pre-analytical part of test is very important because sample collection and correct sample collection is very, very important. Correct sample and correct sample collection in the correct container. And what we did, of course, sample in formal saline was taken out and washed with normal saline and sent for microbiology. Treatment, because we don't know, because this is multiple liver and spleen abscesses and we never know what it is, because there are several reasons which can cause abscess-like things. I mean, it could be abscess, it could be metastasis as well. At this moment, we were not sure, but the thing is, patient had fever, high fever. So, covering most common organisms, we had started meropenem and clindamycin, thinking that if it is even MRSA, there's a chance to that it will be covered with clindamycin. So causative organisms of liver and splenic abscesses, enteric organisms can cause, like E. coli, Klebsiella pneumoniae, and Streptococcus milleri group is streptococci, which can cause abscesses in any organ, like even liver, spleen, brain, lungs, wherever it is. It is an oral organism, but it can be spread through the blood and cause abscesses. And other very important thing in our country is the Cholera pseudomallei, which cause melioidosis, and we see many melioidosis patients in all over the country. So we'll have to be vigilant for those two things. So we got gram stain. We could see some gram-positive cocci, and direct culture didn't grow obviously because it was the organism might have been killed by formal saline. Then we enriched the VHI. At the same time, we got the call from our histopathologist at Morele at that time, Dr. Manjula, that he had seen some gram-positive cocci, and he called me and we had a look and thought it could be staph. So we didn't have facilities to take photographs. So that is about 5-6 years ago. I took the samples here, and Partha took the photographs for me. And so it supported staphylococcal infection, and we could carry on treatment on staphylococcal, because otherwise we'll have to cover all the organisms, like possible all the organisms, including Burkholderia. It's a waste of money as well as resources and everything, and radiology support as well. So fortunately, again, enriched culture, we could grow Staphylococcus aureus after 72 hours, which was sensitive simply to coprofloxacin. So we could come back. This is the fever chart, and with treatment, the fever settled, of course, because we knew the organism and the sensitivity. Treatment changed to intravenous cloxacillin. We didn't have fluclox at that time, and the size of the lesion reduced, and inflammatory markers as well, and the patient was fever-free by 5th day. And of course, these are, just because it was a real scenario, I just wanted to add a few things as well. A patient developed skin rash on the 25th day of cloxing, which can happen and consultant dermatologist had a look, and without omitting fluoxetine, he managed with antihistamines. And CT chest and all showed there were no other organ involved, and antibodies done in any case for Burkholderia pseudomallate, it became negative. So a patient was treated with IV fluoxetine for 6 weeks and discharged on oral fluoxetine for 3 weeks after giving vaccines, and the plan for prophylactic antibiotics indicated for asplenia. Discussion. Atypical presentations. It's because he has had a fall, and but it was not mentioned on admission. So you will find very odd things when you go through the patient's history. In this case, a laparotomy was performed due to the splenic rupture. So here, although apart from the fever, there was no signs of splenic or liver involvement of staph infection. Usually Staphylococcus infection is severe, but this has been very non-acute thing. Could have the child's life must have been actually saved by the fall, which caused splenic rupture. So biopsy is taken for histology microbiology. Previous we have this tool. So these are the things from lab side, but we want to emphasize. We have to do the cultures. I'm always telling, whatever you take out from the patient, please send for us a small piece in a sterile container always, because we can find some organisms there and properly collected. Take home message. Again, I don't know what happened really. It was a nice slide. So what can I do? Anyway, correct the type. Correct type of specimen. We have to decide the correct type of specimen. Samples should not be in contact with disinfectants or antiseptics, because it can cause killing of the organisms, which happened in this occasion. And avoid contamination with the common cell microbiota also, because when we get bone sops like samples without cleaning the site with normal saline, we will grow the colonizers, which will be resistant and which will be useless to do the sensitivities as well, because they are not causing, most of the time they are not causing infection. So if it is a wound, we want the wound clean with normal saline and a deep swab. And if it is aspiration, of course, you can clean the site with either soap and water, or you can clean with alcohol and leave it dry, and aspiration can be done. Transport in a correct container without delay to the lab. And correct laboratory procedure will be done in the lab with all the support above. Post-analytical phase will be done correctly, and you will get a proper results in that case. You have seen this picture earlier as well, because all the phases are very important: pre-analytical, analytical and post-analytical, to treat a patient. In a little recent picture here with the same message, because it is very important. We want the history and clinical details as well. Thank you.